Tori gave a really nice introduction to melanoma diagnosis, and also highlighted, as Victoria did, the importance of MPA in the role that it has in highlighting to patients what is best standard of care, and also highlighting to us as the clinicians the patient's focus, although obviously that drives a lot of what we do. So the overview of what I'm going to talk about is the role of surgery. First, I'll talk about surgery for primary melanoma, which Tori's already touched on a little, but I'll expand on that. Both the treatment of the melanoma itself, but also lymph node surgery, where the main role is to treat the melanoma with minimal morbidity, but also optimize patient risk assessment. The other aspect that I'll talk about towards the end of the talk in less detail is surgery for advanced melanoma. And throughout all of this, Tori's already touched on this, but I will go over and over and over again about the importance of the multidisciplinary team, because essentially the key to achieving optimal outcomes is to having input from a diverse range of experts in the field. So melanoma is a big problem in Australia. There's about 16,000 patients diagnosed with melanoma in 2020, and about 1,400 deaths. The good news is that for the first time, we're seeing that number of deaths starting to come down. And that's largely as a result of the implementation of successful systemic therapies, which I'll touch on, but will be discussed in more detail in the future talks in this series, which I would encourage you to join into. The key point here, though, is that most patients with melanoma are cured of their disease, and the treatment modality that is most successful for most of those patients is surgery. So most patients with melanoma will never see or never require any drug treatment, and will be cured of their disease with an operation. And what I've shown here is the survival curves according to patients' stage. So for those of you unfamiliar with the concept of staging, so staging is something that's applied in all different cancers, and it's where we use characteristics of a patient's cancer to provide risk stratification. For different cancers, we have different aspects of the tumor that we use. In melanoma, the main 2 points that we look at are the Breslow thickness, which is the number of millimeters that a melanoma penetrates into the skin, and whether or not the melanoma has ulceration on the surface. So when a patient sees a GP or a dermatologist and they think this lesion could be melanoma, and as Tori described, the lesion gets cut out, that gets sent for pathology, the pathology report comes back, and the two main features that we look for are the Breslow thickness and the ulceration. What you'll notice is not shown on this slide, but I will highlight because it is a source of confusion, is something called the Clark level. And for those of you who might have had melanoma in the past, you might have had highlighted to you that you had a level 3 or a level 4 melanoma. That could be quite a confusing aspect of the pathology report, because level 3 and level 4 sounds a lot like stage 3 and stage 4, which are completely different. So level 3 and level 4 talks about how many layers of skin the melanoma has penetrated. And while there is some impact of the level on the outcome, it's much less significant than the thickness. And so we generally don't worry about the level. And I'll talk about what the staging actually means. But I would encourage any of you who have had your doctors tell you about the level of your melanoma and that level is bad, to just ignore that piece of information because it's not particularly helpful. So the extent of the primary melanoma generally guides the amount of surgery that a patient needs. So this is a patient who I saw in the clinic about 10 years ago, who'd had his surgery about 20 years before that. And in the past, there was a dogma that melanomas needed to be excised with a very wide margin. So he would have had a 5 centimeter margin with 5 centimeters of normal skin removed all the way around the melanoma. What you'll also notice is that he has a big swollen arm on the left side, and that's because he would have had all of the lymph nodes removed on the left side. That sort of surgery is not really done at all anymore, but it's a really good portrayal of where melanoma surgery used to be in the past. So the aim here is to widely excise the primary tumor with an adequate margin of normal tissue to minimize the risk of local recurrence. And for a long time now, we've been debating over what exactly is the definition of an adequate margin of normal tissue. So this is what the current Australian guidelines say. So for an in situ or a precancerous melanoma, the recommended margin is 0.5 centimeter. For a melanoma less than 1 millimeter, it's a 1 centimeter margin. For a melanoma of 1 to 2 millimeters, it's somewhere between a 1 to 2 centimeter margin. And when it's more than 2 millimeters thick, we recommend a 2 centimeter margin. So that's 2 centimeters of normal skin all the way around the melanoma. You can see here what the difference is between a 1 centimeter margin. So this is a melanoma. There's the scar from the original excision. We've added 1 centimeter around it, and that is the skin within that ellipse that will be excised. In most cases, when you take out 1 centimeter of skin, you can just close the two edges together and end up with a straight scar. In this case, the scale is obviously different, so it's a little bit deceptive putting them next to each other. But this extent of surgery, which is 2 centimeters on either side of the scar, will leave a 4 centimeter defect, and often that is not able to be closed primarily, and so this patient needs a flap to close the wound. And so we have asked the question, as have many others, whether patients really need a 2 centimeter margin. And again, I'll highlight the great work that the Melanoma and Skin Cancer Trials Group's doing, and Tori in her role on the executive of that, or the board of that, is critical in the success of MASK or MASK. Basically, we are running an international trial to try and see whether or not a 1 centimeter margin is adequate for all melanomas. So this is a trial that was open. We were successful in getting funding from the NHMRC, and we're running a trial of hoping to recruit 3,000 patients from around the world over the next 5 years. And hopefully in about a decade from now, when we get the answers, we will show that a 1 centimeter margin is adequate and the 2 centimeter margin is no longer required. But for now, patients still are treated according to the guidelines. But if you do have a new melanoma and you do come to one of the recruiting centers, it's quite possible that this study will be discussed with you, where we're randomizing patients according to a computer to either 1 or a 2 centimeter margin to provide the evidence that we're looking for. The next important thing to talk about is sentinel lymph node biopsy. So what is this procedure? Basically, skin all over your body drains to lymph nodes. What do lymph nodes do? Lymph nodes look after that part of your skin. If an organism or a bacteria gets in through the skin, the lymph node is where your immune system sees that organism and fights it. But in the same way, if a melanoma starts to grow on the skin, when it starts to spread, often the first place that it'll spread to is to lymph nodes. And we have a test where we can find which lymph node looks after the piece of skin where the melanoma arises. And we can take that lymph node out, give it to the pathologist so that they can look at it under the microscope and tell us if there's any cancer in it. That's a sentinel lymph node biopsy. We use a procedure called a lymphoscintigram, which is a nuclear medicine procedure to find the lymph node. So you can see here, this patient had a melanoma on their neck that was injected with a tracer, and that tracer has gone to 2 separate lymph nodes. one up here in the top of the neck, one down here in the bottom of the neck. These are the two sentinel nodes. So this scan doesn't tell us if there's cancer in it. It just tells us which lymph nodes we need to take out to give to the pathologist for them to tell us if there's any melanoma in it. And here's the procedure of removing the lymph node. You can see we've used both that probe, the gamma probe, but also we used some blue dye. This is a different patient. The melanoma is on the scalp up here. You can see the hole from where we've cut out that margin. And you can see here a small cut to find the lymph node, which has the blue dye in it, which we'll take out and send to pathology. So why do we do this procedure and who should have it? Well, the reason we do it is because whether or not there's melanoma in the node is the most important predictor of how the patients will go from the point of view of the risk of recurrence and of dying from melanoma. And the risk of the node being involved varies depending on the patient tumor factors that we talked about earlier, that is the Breslow thickness and that presence or absence of ulceration. And so undergoing sentinel node biopsy itself does not necessarily increase the survival of patients, but this is not necessarily surprising because many patients who have a sentinel node biopsy don't actually have any cancer in their node. So they're not actually going to be able to have a survival benefit from removing the lymph node. But what they do get is the reassurance that their melanoma is of a lower risk. So I've put here a patient example. This is a 50-year-old man who has a lesion excised from his arm, which shows a 1.8 millimeter ulcerated melanoma. So this is a intermediate thickness melanoma, and he has approximately a 20% risk of lymph node involvement. So if this patient's lymph node is negative, that's an 80% chance. He would have a stage 2A melanoma with a reasonably good survival. By contrast, if the lymph node is positive, it's a stage 3 melanoma, still has a much better than even chance of not dying from their melanoma, but the risk of dying is about double. And so patients in this group would be in the current era recommended drug treatment and certainly recommended closer surveillance. And I'll get to those 2 points in a minute. So this is, we talked earlier about staging. So this is the staging table where we look here across the top at the primary tumor, how thick it is from T1, 2, 3, 4, the number of millimeters that the tumor goes into the skin, and whether or not it's ulcerated, which is B, or not ulcerated, A. And you can see that as the thickness goes up, the stage goes up. So this is stage 3A, 3B, and 3C. But then also here you have how many lymph nodes are involved and how big the lymph nodes are involved. So as the number of lymph nodes go up, similarly, sorry, I just stopped my share for some reason, share screen. Sorry about that. As the number of lymph nodes goes up, so does the stage. So you can see here, these are graphs of survival. Patients with stage 3A disease with an early melanoma and one microscopic deposit of melanoma actually have a very good prognosis, but as the thickness of the melanoma goes up and as the number of lymph nodes with melanoma in them go up, the prognosis of the patients becomes worse. So what do we do if the lymph node is positive? Well, in the past, that was an automatic indication for going in and taking out the rest of the lymph nodes. Now, taking out the rest of the lymph nodes is an operation that has quite significant morbidity and side effects. And so a study was done to see whether or not it was okay to just do regular ultrasounds instead of doing surgery, and then doing surgery only if the ultrasound showed that another lymph node was enlarging. And that kind of made sense because the majority of patients with one node found at sentinel lymph node biopsy, sorry, one or two or however many patients found with sentinel node involvement don't have any more lymph nodes with cancer in it. And sure enough, the results of that study showed that there was no benefit to going in immediately to remove the rest of the lymph nodes. And so now if a patient has a positive sentinel node, we routinely put those patients onto a surveillance program where they have regular ultrasounds and scans. And only if that shows other nodes starting to grow would they go on to have further surgery. Because really what benefits patients with lymph node involvement is drug treatment. And you'll hear more about this from the speakers later in the series, but I'll highlight a couple of the seminal papers here. This is a paper where immunotherapy was used, and nivolumab is an immunotherapy agent targeting a molecule called PD-1. And you can see here, when that drug was compared with an older immunotherapy agent, the survival of patients, or the recurrence-free survival, that is the time to their cancer coming back, was significantly improved. And these drugs have reduced the risk of recurrence for patients after surgery for stage 3 melanoma by 1/2, which is a huge improvement in outcome. So a 50% improvement in survival for these patients. And that has dramatically changed our standard of treatment for patients with primary melanoma. This is similarly using a different class of drugs. So you'll hear later in the series that about 1/2 of melanomas have a mutation in a gene called BRAF. And if a melanoma has that mutation, then we can use a different class of drugs to immunotherapy where we target that mutation. And similarly, you can see this improvement in recurrence-free survival and in overall survival, that's that blue line, in patients receiving treatment with the targeted therapy versus placebo or no drug treatment. So you can see that closer this line is to a straight line along a straight horizontal line, the better the outcome for the patients. So what's the downside to a sentinel node biopsy? Well, it is an operation. There is a risk of wound infection, seroma, which is fluid accumulating where the lymph node's removed, or mild lymphedema. There's also a false negative rate. That is, that if the lymph node test comes back saying it's negative, actually there was a small amount of disease that was missed. But we did a study at Peter Mac where we took 100 patients who'd had a negative sentinel node biopsy and assessed for their complications and asked them about their experience. And the vast majority of patients strongly were supportive of the treatment. So this is the Australian guidelines, which recommend that patients with sentinel node biopsy should be considered for all patients with melanomas greater than 1 millimeter thick, or for melanomas more than 0.75 millimeters thick with other high-risk pathological features. So what about patients with palpable nodes? That is where the nodes can be felt by the surgeon or the clinician. These patients traditionally are treated with surgery. Well, first they undergo staging where we do scans to make sure there's no other evidence of disease, and then they undergo surgery to remove all of the lymph nodes that can be felt, as well as the other lymph nodes in that nodal basin. These patients would generally be recommended for drug treatment, and more now we're actually giving the drug treatment before the surgery. And I'm not going to go into that. We call that neoadjuvant therapy. So instead of doing surgery first and drug treatment to follow, we're now starting to give the drug treatment first for a period of about 6 weeks, and then do the surgery afterwards. And there are a number of benefits to doing it that way around. This is a type of disease called in-transit disease. You can see here, this is a patient's leg, and that's where the melanoma was initially found. That's a skin graft, and you can see these spots that have popped up around it. About 5% of patients whose melanoma recurs will recur with this type of disease pattern, and we have a number of options for how to treat this, including surgery if it's limited in volume, including limb infusion where we put the chemotherapy into the leg, including various injections, and more now with drug treatment. And then stage 4 melanoma, which is melanoma that has traveled beyond the lymph nodes to other sites of disease. Sometimes surgery is considered here as well. Obviously, this is dependent on the discussion within our multidisciplinary teams. We don't usually use surgery first in this setting because the drugs are so effective. We usually give drug treatment first. But sometimes after they've received drug treatment, if a particular spot of melanoma won't go away or it just continues to grow, we would consider surgery to remove that area of resistant disease. So in conclusion, surgery is a very important part of the treatment for the majority of patients with melanoma. For most patients, surgery is the only treatment they need and is curative. And large studies have shown that equivalent outcomes can be achieved with less surgery. So whereas previously we used to take very wide margins, we're now taking narrower margins, and hopefully in the coming years we'll be taking even narrower margins. Where we used to take lots of lymph nodes, we're now taking fewer lymph nodes to try to make the surgical impact on patients' outcomes as minimal as possible.